Introduce yourself and move forward.
Great. Thank you, John, and welcome all. I appreciate the opportunity to uh, share our vision and our program. We started this vision about 9 years ago when Suboxone began to become popular, and particularly in our community with the rate of overdose, the rate of addiction, and the rate of utilization of hospital emergency departments. It seemed only prudent that we developed some better mitigation strategies to address this. Next slide. And as John mentioned, I serve presently as the inaugural Dean of the Tawny College of Dentistry. We'll be welcoming our first class in less than 8 months, August of 2025. And we have a rather robust interest. For 50 seats, we have over 1,450 applications we're going through. So we're pretty excited with regards to that. Yep, there is a lawsuit about Suboxone effect on teeth. We'll get to that later on. Next slide, please. So the objectives I'm preaching to the choir here when I talk about the three FDA-approved drugs that are utilized with recovery. But more importantly, today we want to focus on the oral health implications resulting from the therapy and kind of a catch-22 situation that has arisen as a result of the Suboxone preparation, and learn how important it is that a dental prehabilitation, perihabilitation, and post-habilitation continuum of care be initiated. And there are ways to create direct linkages operationally with these individuals. And so in 2027, the Botany College of Dentistry will be one of those sites. Next slide, please. I put this slide in here because, of course, this received national prominence on the news, but these were actually patients of ours. We have mobile dental vans at St. Elizabeth, Youngstown Hospital, Bon Secours Mercy Health, and we go down to East Liverpool, and we actually were providing dental care to this particular set of grandparents and the grandchild. The dentist roles hopefully will be made more significant as we move forward. Next slide. So the three FDA-approved medication-assisted therapeutic drugs, as we know, methadone, we won't focus at all on today. Buprenorphine, one, and then the combination of buprenorphine and naloxone with regards to the oral route of administration. So next slide. Interestingly enough, all these medications have an oral route of administration. That is the primary cause of the destruction that subsequently will occur. The Suboxone combination is most commonly provided via a buccal film that's dissolved in an oral cavity for 15 or 20, 30 minutes with the instructions thereafter: don't put anything in your mouth for the next 30 minutes because bioavailability of that drug is not so great. Next slide. So while we do know that MOUD is an extremely effective plan of care, particularly if we can induce the patient with first dose in the emergency department and then a direct linkage, that works well in the addiction recovery plan of care. But unfortunately, Suboxone, with its pH and its sucrose, promotes dental caries in an already high-risk caries population. It's important to note that dental decay, dental caries, is infectious, it's contagious, it's transmissible, and it self-inoculates. So what we actually talk about in these individuals is that they actually have active dental decay that they can continually self-inoculate one another. And so one of the new strategies that we're going to talk about is silver diamine fluoride, a way to arrest dental decay. Most of these individuals are showing up with 16 to 18 teeth that require repair. Just almost impossible to, by the time you repair 4 or 5 teeth, they present the next visit with another 2 to 3 teeth already infected. Next slide. So These patients, as you're all well aware, present with severe xerostomia, total lack of saliva. That creates a lot of problems for us. Salivary functions include lubrication, not only of the soft tissues, but the oral tissues as well, including the taste buds. Because the taste buds are significantly altered, these individuals have significant cravings for high sugar and carbohydrate-rich foods, which actually feed right into the perfect storm, providing substrates for metabolism and subsequent acidic production, the so-called Mountain Dew effect. We also know that saliva buffers, it remineralizes teeth, it provides a protective biofilm, and it aids in the mastication, digestion, and taste processes. So a lack thereof creates significant problems. Next slide. So if we take a look at Suboxone films, whether we administer buccally or sublingually, the pH of this is 3.4. The pH of a normal mouth is roughly 6.8. And so the microbiome that occurs in the mouth on a normal basis at 6.8 has a fairly balanced attack where the bacteria that produce acids are balanced by the bacteria that don't produce acids. So it's kind of a homeostatic effect. The challenge is once the oral environment gets below 4.5, then all of a sudden we have a natural selection process occurring where in the acidophilic bacteria, those that actually thrive in that environment, unfortunately, are also the acidogenic bacteria, those that produce tremendous amounts of acid. So if it weren't bad enough that we put a pH of 3.4 in an already acidic mouth with active dental decay, then we flavor it with sucrose so that we are adding to the substrates for metabolism. And of course, the 15 to 30 minutes to dissolve and refrain from food or liquid. Whether the administration is sublingual or buccal, this is the metabolic disaster that occurs as a result of these processes. Next slide. So we do know why we've packaged buprenorphine with naloxone. And as we conclude today, I'd be curious to understand from everyone what the roles are. Our former addictionologist was a big proponent of buprenorphine tablets sublingually for this reason, and he cited lots of studies in Europe. I'll defer that to the experts, but if indeed that were available and feasible, that would solve lots of the challenges that we're going to address today. Next slide. So it's either taken sublingually or buccally. And as we know, next slide. Beat this horse till it's dead, but it's the acidic pH. It's the poor bioavailability, the existing xerostomia, and the sucrose flavoring, in addition to the taste buds that are craving high carbohydrate, sugary foods, resulting in the Mountain Dew effect. So next slide. So dental decay or dental caries, as we mentioned, it is infectious, contagious, and transmissible. So if an individual has one carious lesion in their mouth, very likely that next time you see them, they could have 2 or 3. They self-inoculate. And so one of the challenges that, next slide, dental decay is multifactorial, but what we're processing on today is the fact that we have an acidic environment that's being enhanced, and we have a microbiome that's being fed tremendous amounts of sugar, carbohydrates, without any of the buffering of protective effects of saliva, without any of the remineralizing protective effects of saliva. So these teeth go south badly. Most of the literature demonstrates that patients will lose 20 teeth within the first 300 days of induction. Next slide. So dental decay, demineralization, is actually a dynamic continuum where we have acid breaking down the tooth structure, and hopefully saliva providing lubrication, providing buffering, and providing remineralization. Unfortunately, all of the protective factors, salivary flow, fluoride exposure, healthy diet, plaque control, oral hygiene aren't in the favor of our patients, as we all too well know. Next slide. So what happens in these individuals, and in all of our mouths as well, is that pH and dental caries is remember, things entering the mouth, that's the first stage of digestion. So as we actually put something past our lips, we'll actually get a momentary decrease in the pH of our saliva, and then it will actually remineralize or return to homeostatic pretty quickly in 10 to 15 minutes. That's in our normal environment where we have saliva that buffers, saliva that can remineralize. But these individuals, and you'll notice this, we notice this when they come in for their visits initially, they'll come in holding a Mountain Dew bottle and snacking continuously. Each time something passes your lips, rather than having the opportunity to have the pH return to normal, the pH will go from 7 to 5, and then it'll peak up maybe to 5.5, but then if they have another snack, it goes down, down, and down. So it's also the eating and behavioral habits of these individuals where they have snacking or sipping caries. So individuals, we learned this the hard way. About 15 years ago, we noticed that students going to college would come back after 6 months for their dental checkups, that they were generally in a caries-free environment. And they would come back and they would have 2 or 3 carious lesions in a situation where their caries risk factors early on for the first 18 years were not very significant. So the question was, do you drink soda pop? And the answer was sure. And the next question we asked was, well, how many? They say 1. And unfortunately, we weren't sharp enough at that time to ask the more important question, how long does it take you to drink that soda pop? All night. So every sip they take, they were taking their pH and dropping it down. So as we now know, sipping caries is actually a diagnostic criteria with a treatment protocol, not unlike what we're going to discuss shortly. Next slide. So we do know that medical and dental knowledge severely lacking in this arena. In fact, those of us who were advocating for some sort of warning by the FDA eventually did come to fruition. But we do need to establish evidence-based protocols so we can, number one, intervene at initiation, slow the progression of carious lesions, because if we don't circumvent the progression of the disease, you'll have individuals that are well on their way to recovery. And if anybody's on the program that has had a severely abscessed tooth, you'll know how significant that particular tooth is. And unfortunately, while we've educated our prescribers with regards to how to manage pain better without narcotics, far too often these patients will present with their primary care physicians in excruciating pain, and the primary care physician and or dentist, being well aware of the recovery journey, won't adequately manage their pain, and then they end up on the street, and then it's a whole another circle. Oftentimes those individuals are presenting to our hospital emergency departments. Not surprisingly, the number 1, number 3, and number 12 top visits to hospital emergency departments for level 1 and level 2 are all dentally related. So we want to try to circumvent this relapse. Next slide, please. Finally, in January of 2022, the FDA released a drug safety communication. This took a bit of a battle because they weren't too excited. They were more focused on the pre-existing conditions of these individuals. But we did get the statement finally to say dental problems, including tooth decay, cavities, oral infections, and loss of teeth, can be serious and have been reported even in patients with no history of dental issues. So not only is it a perfect storm for allowing the progression of the disease process, but it can allow for the initiation of the disease process. Next slide. You've seen these teeth. That's an individual from heroin use, but the mechanism is the same, pH. All of those sites are actually infectious, contagious, and transmissible. Next slide. Again, meth mouth. We find these individuals, once this happens, we are chasing the dog's tail. And so the challenge has been for years, we didn't have a great way to manage these individuals. Most of us are familiar with dental therapies consisting of surgical management. Take a handpiece and drill, excavate, and remove all of the infected tooth, and then restore and repair it with materials. The challenge is you can't do that unless you put that patient to sleep for 12 hours and restore it. So rather than the traditional surgical model of management of decay, we needed to shift to a medical model of management. Now, the medical model doesn't look as pretty, but it's far more effective. Next slide. And of course, these individuals present with other comorbidities as well with regards to infectious disease processes. Another slide. And individuals, in addition to the rampant caries, they often get fungal overgrowth as well. Again, the pH being significant in oral candidiasis can be extremely painful in burning mouth. Next slide. Conversely, if you note these teeth and you were to take a look at them, you'd be very concerned, but we've actually treated that patient already. Okay, and so you see the rather dark black stain in those teeth. That's actually from a material called silver diamine fluoride. So some of us are on this program that might remember the use of silver nitrate sticks. In the very old days, in my residency training, we always had silver nitrate sticks in our lab coat because it was a great way to cauterize and stop bleeding. And basically, in China, in Europe for many years, as well as in India, they have a paucity of dental providers, but they've used silver nitrate sticks to actually treat dental decay because they can cauterize it. Well, we've gone one step further, and silver diamine fluoride, which is a combination of silver nitrate sticks with stannous fluoride, can actually arrest that decay on contact. So basically, this individual comes in, and now there is a toxicity concern with regards to how much of that you can place in the mouth at one time. So basically, we've painted these teeth with these liquid drops, and we've arrested that decay. You know, 1 or 2 visits, we can have all of the dental decay arrested in this patient's mouth. Then we can restore. Too often, we were focused on a population where if you have one teeth requiring restoration, very simple to repair. But in this situation, if we focused on repairing a couple teeth, the other side of the mouth would be inoculated, and we'd have chasing the dog's tail once again. Next slide. And one more. So if we take a peek, what ends up happening to these teeth is because of the acidic environment and the dryness, they do oftentimes become extremely brittle, and they do break off. So these individuals, they break off, and you can see on the gum right there, there's actually a purulent tract on the bottom right side where there's actually pus coming right out of their particular gums. Those individuals, at that point, it's interesting, once the infection finds a way to drain out of that particular gum, those patients are not in that much pain because the pressure's been relieved. And so anecdotally, you would think, wow, look at the size of that lesion. That's as bigger than a pea. They should be in pain. No, their body has found a way to relieve that pain. Individuals who don't present with a perilous or don't present with an active draining fistula, they're in the ones that are in exquisite pain because their periosteum's being invaded by these pressures that are being generated by the hydraulic pressures within the bony trabecular. Next slide. I should mention, unfortunately, none of these slides are from the internet. These are all our patients in Youngstown, Ohio, and it doesn't take very long to collect these. So Don't want to make radiologists out of anyone or dental imaging, but you can take a look at the devastation in this mouth. And basically, this individual's in their 30s. And so, how do we, number one, how do we get this patient comfortable? But number two, a new initiative we've created is if we get this patient dentally comfortable and you have them well on the road to recovery, how are they going to rejoin the workforce with an appearance like that? So we've partnered with the Ohio Department of Health, and there's some excess revenue funds where we've created a program. We make dentures for these patients to get them back into the workforce. Next slide. Again, we take a look at the devastation of these particular teeth, and particularly affects the front teeth and the smile, and then workforce becomes an issue. Next slide. So these are individuals here that have tremendous amounts of devastation, and oftentimes not enough teeth remaining that would be substantial for them to masticate and speak and communicate, let alone smile. Next slide. And again, you can see the tremendous devastation there, all of the abscesses in the jawbone. And this certainly adds to a tremendous amount of exacerbation of pre-existing chronic conditions as well. So if these individuals are diabetic, they have cardiovascular disease, they're hypertension, all of those are affected and exacerbated significantly by the sepsis that is circulating. Next slide. So dental prehabilitation, this is the big take-home lesson today, is we need, if we can, to get a patient linked for dental prehabilitation with the caries risk assessment, radiographs, evaluation, we've only focused on the teeth thus far, but the other component is periodontal disease of the bones and gums as well. But we want to make sure that we actually address this and get a plan of care. Next slide. So there actually are caries risk assessment forms. Most of us on this call probably have never seen this or never been asked for it. Usually we're in the category of low risk. In other words, our dentist may be doing the caries risk assessment and has your history down. So you may not hear this. They probably are doing that. But caries risk assessments are something that's going to work out very nicely as we move forward with where we're at. But these actually, the insurance industry is actually beginning to understand that, hey, if these individuals are at high risk and they're diabetic or they're in recovery, there's going to be some cost avoidance and downstream savings if we address their issues and pay for them here rather than downstream. And downstream way too often is in the hospital emergency department. Next slide. And one more. So we actually developed a dental management for pre-Suboxone initial clearance in our providers in our area. We'll send the patients to us and we'll actually give them this particular clearance form so that from a benchmark standard, this is considered standard of care. And then, as we mentioned, urgent care doesn't always have to be definitive care. It can be medical management. And again, can't stress enough what a wonderful silver bullet silver diamine fluoride is. You can paint those teeth and arrest the caries, and it's becoming extremely commonly used, not only in this population, but if we go back to one of those initial slides where we're down in East Liverpool in a area where there are very rural and there's no access to dental care. If we go down there, the best care we might provide is continuous applications of silver diamine fluoride. So medical management, while the teeth don't look good as they leave, we've arrested the decay in the process and done the patient a great service. Next slide. So the initial clearance protocol, as we move forward, in the exam, and we want to make sure there's a couple things that we can do as far as mitigation strategies. And so if we are going to administer the Suboxone, then we know that we can try to rejuvenate the salivary functions in a number of ways. So we can actually make these patients custom fluoride trays. They look kind of like an athletic mouth guard, and we provide them with prescription fluoride so that after they've had their strip dissolved in their mouth, they can actually then go ahead and rinse their mouth. And this is critically important. Don't brush your teeth with all that acid in your mouth. That would be the same as taking a toothbrush and dipping it in battery acid. Well, by the way, battery acid has a pH of 2.6, Suboxone 3.4. So there's not a big difference there. So what we ask is that if after the individual's done, if they want to brush their teeth, rinse their mouth with a teaspoon of baking soda in warm water first. That will neutralize. Simple. Now, there is a whole myriad of dental products called Carie-Free, Carifree. Carie-Free are all designed with regards to addressing dental disease via a pH mechanism. So they have toothpaste, they have mouth rinses, they have gum, and we'll talk about xylitol in a minute. So these individuals, we can make them custom fluoride trays, much like we do in our patients with head, neck, rat onc, give them prescription fluoride toothpaste where they're getting 5,000 parts per million, microbial rinses, chlorhexidine. Chlorhexidine rinse, you wouldn't know it as Peridex or PerioGuard. We, in the real old days, Hibiclens, if you're familiar, Hibiclens was our pre-surgical scrub when I was a resident. For reasons that weren't altogether clear, we knew Hibiclens was a wonderful oral rinse. We weren't allowed to prescribe it in this country, so we compounded our own Hibiclens 50 years ago, well, 44. So it works extremely well. Zero stone management. It's best not to call these things salivary substitutes because that conjures up an image of the individual going to the blood bank, giving out blood. You know, if salivary substitute, you'd conjure up an image of somebody with their tobacco in their mouth filling up their spittoon. So we call them oral lubricating agents, of which there's lots and lots of those. And then one of the items that you, in the state of Ohio, you can actually do is you can train your medical team to apply fluoride varnish, and it's actually reimbursable. So this is not silver diamine fluoride, this is fluoride varnish. So after we arrest the decay, we can actually paint fluoride varnish on the teeth. Next slide. So we're talking about caries control, that's the huge issue, and then periodontal control, which if you're controlling the dental decay, you're actually unintendedly controlling the periodontal disease as well. Next slide. So lots of all these measures are supportive. Sodium fluoride, Prevident, that's a prescription toothpaste. We talked about PerioGuard. Silver diamine fluoride, that should have 10 stars around it. The custom fluoride trays or the fluoride varnish application. Xylitol gum is wonderful. Xylitol gum, it has to have xylitol as its primary ingredient. And so there are a few. Spry, the other day I was at Starbucks and picked up the mints while they were getting my coffee, and they actually, their mints have xylitol as a #1 ingredient as well. Xylitol is a wonderful agent. It actually prevents bacterial metabolism of sugars in the mouth, so it prohibits decay. We use xylitol in our centering pregnancy with our expectant mothers, having them chew 6 to 8 sticks of gum a day. If you're chewing xylitol gum, of course, that's going to stimulate salivary effects. And before you go on the internet and say, well, xylitol will cause severe diarrhea, you're 100% right. If you were to chew 1,400 sticks a day, you could get into that problem. But you'd probably be seeing me for temporomandibular joint disuse function before that. In oral neutralizing rinses, something as simple as a teaspoon of sodium bicarb on a continuous basis. Just when their mouth gets dry, please don't have them carry their soda pop or their Mountain Dew. Have them carry their bottle with a little bicarb. Great question. You stole my thunder. As we talked about caries free, there's a whole bunch of salivary products called biotine. Biotine makes gum, toothpaste, oral lubricants, mouthwashes, wonderful. There's also a whole series of products called green tea products, was developed by an oral health researcher down at Augusta Medical College when his wife developed oral cancer and was going through all of this. So if you see the zero stoma management, we actually do have biotine listed there. There are some cholinergic agents you can use to stimulate saliva, but in my shop, that's a no-no. These patients have far too many drugs already in their body. We don't need to be introducing more. And in my experience, those haven't been nearly as effective. Patients are willing to chew gum and mints, and the mouth is dry enough. If they're going to do that, give them Spry or some of the other xylitol containing gum. It's important to note, and we sent a nasty note to Trident, because when all of the xylitol information was being propagated and being assimilated into our continuums of care, Trident came out with their banner in the upper left corner, said now with xylitol, which was accurate, but it was the third ingredient, which meant it was totally non-therapeutic. Why the other sugar alcohols, so sorbitol and mannitol, and not xylitol? Because xylitol is the most expensive of the sugar alcohols to produce and incorporate, but it needs to be that. So over in Europe, they actually have their children in school chew 6 sticks of xylitol a day because they can't brush their teeth, as a public health measure. We've tried repetitively to do that. The teachers feel as though the students are going to stick the gum underneath the desk or whatever. And you know what? They probably will, but they do anyhow, right? Next slide. So here's the Ohio Department of Medicaid that actually will act to demonstrate that as a medical provider, you can actually get reimbursed for providing fluoride varnish services. And basically, it's a very simple 15-minute course that you can. It actually has your CPT code right there, 99188. So it's reimbursable. They do have restrictions with regards to that, but you're doing the patient a great favor and great service. And I think you get reimbursed 3 times a year for that. But each time you see the patient, probably not a bad idea. That's how we do it. Next slide. And sometimes simple is way better. And so baking soda works wonderful. A research project that we just began to initiate pre-COVID, and then of course we pivoted, and so we haven't returned to this yet, is we are taking pH measurements of the saliva in the patients before their Suboxone treatment, and then taking them immediately thereafter, and then having the patient rinse with the bicarb and taking a third measurement. And it's as simple as, there's a pH meter that we reached out to a company and they provided them to us. So we're in pretty good shape with regards to that. But this is simple. The other products are great as well, but everybody has this, and this costs nothing but peanuts. But more to come on those studies. I think everyone on this program understands what we're going to find. What we're trying to discern is how significantly that pH goes up and how long it takes to return to a decent level. So perihabilitation, next slide, please. Perihabilitation efforts. Again, silver diamine fluoride, that's the champion. Now, is there anything wrong with that? Oh, yes. So silver diamine fluoride comes in real tiny little single capsules, and you take a little micro brush like and you just paint it on the teeth. Everybody on this program is capable of doing that. What you do not want to do is have it hit anywhere but the tooth, because if it does, you will have a permanent black, brown stain wherever it is. So unfortunately, in our dental residency program, we have lots of those little brown stains, even though we have our residents put barrier covers down. Sometimes they spill it, and it's a microdot, and it just doesn't come off. The big concern with silver diamine fluoride is, as you saw, it does take the carious lesions and take them from the orangish brownish into a dark blackish brown. Well, but they're caries free. Now, occasionally parents, if we use this strategy in children, you need to demonstrate what it's going to look like first before you restore the teeth. Fluoride varnish, as we talked about, can be applied by medical assistants. Prescription fluoride toothpaste, physicians can prescribe that. The xylitol mints and gums are wonderful. Oral neutralizing rinses, you can buy lots of them. Biotin, green tea, caries free, but baking soda works just fine. And zero stoma management protocols are pretty common. Don't call them, you can Zero Lube, Salivart, you buy those at the store. You can also have your pharmacist compound those as well. Next slide. So custom fluoride trays, we can do that as well. Most of the time, those are easily fabricated. And these days with 3D imprinting, we actually don't even need to put the patient through impression procedures. We can actually scan their mouth and then 3D imprint. One of the things we found is you can keep those as a file, and then if they lose, you can refabricate them without having the patient be present, except unfortunately, these patients will break teeth, lose teeth. As you saw, they become brittle. So what you made last month may not be applicable to how they present today. Next slide. So again, periodontal arrests take care of the gums and the bones as well. We rarely use systemic antibiotics to treat periodontal disease unless there's some systemic indications to do so, uncontrolled diabetes. Most of the time, we treat these individuals topically and with the chlorhexidine. And then lastly, next slide, dental post-habilitation. We recommend once we get the caries arrested and or restored, that they be seen on a 3-month recall interval for the first year. Makes great sense. My guess is that in your world, you're probably doing the same. As they are in recovery, they need to be continually monitored. Same with their oral hygiene. And once they become comfortable, sometimes all of these strategies that we've employed to actually get them to that point, sometimes it's easy to forget. So post-habilitation mostly is recare intervals, keep the protective effects of the saliva, whether it be Salivart, Zero Lube, neutralizing rinses, and xylitol. Rarely, if we have no active decay, we don't have to worry so much about silver diamine fluoride and fluoride varnish. Next slide. So, connecting the patients for treatment, we talked a lot about the individuals that come in to see us, but I think it's a great opportunity. I know we had some pharmacy students on there. We actually, our curriculum at our residency program, which I direct and we developed about 9 years ago, we continue on that. We actually have our mobile dental vans now going to recovery centers in our area. So one of the challenges, it's interesting, when COVID came around, we were doing tremendous amounts of school-based dentistry. And for obvious reasons, the boards of education of a lot of those schools said, "Hey, time out. We're going to suspend this practice during COVID." Well, we had a lot of grant dollars and three mobile dental vans and a team ready to go, and we pivoted and said, "Hey, what about our recovery centers?" And that's kind of was the genesis of this situation. So one of our area, we're working with one of the very busy recovery centers in our Tri-County area. We're working to get actually 2 dental chairs put right into their inpatient center. So dental mobile vans are wonderful. Well, any mobile van, whether it be a mammography, internal medicine van, expectant pregnancy, mom's van, they're all great, but they're very expensive. So if we can get that situation addressed by in-house, that would work out pretty nicely. So with that, I'll conclude and see if there's any questions. There are a lot of great comments. So obviously lots of you folks are already onto this. You're familiar with a lot of the products that are out there and are available. Any questions I could answer?
Yeah, there is a lot of comments in there. But yeah,